Good evening, everyone. And I know everybody would find the drug bit a little boring, but I'll try and tell you the most practical usage of the ocular pharmacology drugs in this session. And we'll also give you pointers as regards the relevant MCQs. So, if you remember in part one, we covered mydriatics, cycloplegics, anti-glaucoma drugs, and antibacterial drugs. And in this session, we will be covering anti-allergics, antivirals, antifungals, and corticosteroids. So, for those of you who attended my conjunctivitis lecture, they would be knowing that allergic conjunctivitis is one of the most common and most troublesome forms of conjunctivitis, as not only is it seasonal, but in many cases, it may persist for the entire year because of the presence of multiple allergens in the environment. So the patient can either present as a pink eye with some amount of chemosis or with papillae or follicles in their palpebral conjunctiva and will complain of itching, watering, and persistent redness. So we have to relieve the symptoms of these patients, else it is a cosmetic blemish because the eyes are always looking red and pink, although they are not infective, but still, everybody else around the patient is concerned that this can be contagious and they can also get an infection. So first and foremost, you have to make the patient comfortable because itching is really, really troublesome. So we give antihistaminic drugs. And amongst the antihistamines, we have oral drugs. So you can either give phenaramin or azilastine. Phenaramin causes a little bit of sleepiness, but azilastine or other newer drugs like montelukast or levocetrazine are much less sleep-inducing. What these drugs do is that they block the H1 receptors and they control the itching and capillary dilatation. So if there is capillary dilatation, then histamine and all other itching-inducing agents, they are coming into the bloodstream and being released in the eye. So if you cause capillary constriction, then these agents are not released and the patient's allergic symptoms are relieved. Antihistaminics are usually combined with decongestants like nefazolin, phenylephrine. What this does is it constricts the superficial conjunctival vessels. So there is a constriction of vessels by virtue of which the histamines are not released in the local environment, and therefore redness as well as itching both are controlled. On top of this, if we add cold compresses in the form of using a cool gel pack over the eye or telling the patient to do cold compresses with an ice cube wrapped in a handkerchief 2 to 3 times a day, that will also contribute to additional constriction of blood vessels and will relieve the itching and redness. Then you have to give a proper drug for these symptoms. Earlier, sodium chromoglycate was one of the most commonly used drugs, which is a mast cell stabilizer. This was the first generation drug of this group, but now we have the second generation drugs, and out of that, olopatadine is the most commonly used drug. It is used twice a day. It prevents degranulation of mast cells. It's not really helpful for very acute cases, but it is having a major role in preventive and maintenance therapy. So what we can do is initially we can start with antihistaminics or decongestants and start giving olopatadine side by side, which will start acting within a week of starting the therapy. When only olopatadine or decongestants are not sufficient, we need to add another drug, and usually that is a non-steroidal anti-inflammatory drug, ketorolac, in the concentration of 0.5% given twice or thrice a day. Ketorolac, by virtue of its slightly acidic nature, causes stinging to the patient once it is instilled. Therefore, we suggest our patients to put ketorolac in refrigerator. Once the drop is cool, it doesn't really sting as much. Or what else we can do is in order to take care of stinging, after putting ketorolac eye drops, we can put an artificial eye drop 5 minutes later. That will balance out the pH in the conjunctival cul-de-sac and the patient will have less transient stinging or burning. If, despite adding a non-steroidal anti-inflammatory drug, the allergy is so severe that the patient is symptomatic and you see prominent papillae or follicles in the bulbar conjunctiva, then we add low-dose steroids like fluorometholone, loteprednol. What these do is they also reduce the capillary permeability in addition to causing inhibition of degranulation of mast cells, basophils, and eosinophils. So, in all, we are giving drug combination depending upon whether the patient is having mild, moderate, or severe allergic conjunctivitis. Now, if somebody is having very chronic allergic conjunctivitis, for example, vernal keratoconjunctivitis or vernal conjunctivitis in children, then we can add certain other anti-inflammatory drugs like ribepamide, which reduces dependence on steroids because as we all know, steroids run the risk of making the patient very dependent upon them. And because of that, patient can end up with steroid-induced glaucoma or steroid-induced cataract. Ribepamide is given in concentration of 2% twice a day. This drug also starts acting after initial 2-3 weeks. So it needs to be given for a longer period of time. It also suppresses the production of cytokines by the ocular surface epithelial cells. Tacrolimus is another drug which is also steroid sparing. It's a macrolide basically and is given as an ointment twice a day. It has an anti-inflammatory role as well as an immunomodulatory role. What it does is that in addition to stabilizing the membrane for mast cells, it also suppresses T cell activation and interleukin-2 production. The production of interleukin-2 is contributory to chronic allergic symptoms. It reduces the incidence of recurrence. So if we have a child who is about 4 years old and has VKC, that is vernal keratoconjunctivitis, and we know that this condition lasts for as long as about the child will become a teenager. So every year when the spring comes, this allergy is going to recur. So for those chronic cases, we can give tacrolimus or ribepamide. And in some cases, we can also give cyclosporin as either 0.05% twice a day or 0.1% twice a day, depending upon the severity of the allergy. This drug too is a steroid-sparing immunomodulator, just like tacrolimus, and it also inhibits activation of mast cells and eosinophils. Now, latest studies show that the results of tacrolimus for chronic allergies are much better than cyclosporin, so that is being preferred quite a bit these days. So this is just a pyramidal diagram to show what to do. For mild cases as first-line therapy, we just give topical ophthalmic dual activity agents like olopatadine or epinastin. Epinastin also is a decongestant primarily, which will take care of the itching and redness by virtue of vasoconstriction. Ketotifen and alcaftadine are other drugs. If the allergy is moderate and there is presence of clinical signs and the symptoms persistent itching, persistent pink eye, and watering, then we add topical ophthalmic steroids like dexamethasone, fluorometholone, or loteprednol. Fluorometholone and loteprednol are preferred because their potency is lesser and therefore the adverse effects that steroids induce are much lesser with these drugs as compared to dexamethasone. And in selected situations where the allergy is very severe and recurrent and chronic, we add drugs like cyclosporin, tacrolimus, or ribepamide. Coming to the next class, antiviral drugs. Now, viral keratitis, most commonly that we encounter in our clinics is herpetic keratitis. And herpetic keratitis is of multiple types. You can either have just an epithelial involvement. So in that, we can have infectious epithelial keratitis, or we can have a neurotrophic epithelial keratitis, or we can have a stromal involvement as stromal keratitis, or endothelitis, which is involving the endothelium of the cornea. So here we see a typical dendrite in an infectious epithelial keratitis, and here we see subtle haze that is there in the endothelium, and it is signifying endothelitis. So the antivirals are multiple. Trifluridine, acyclovir, and derivatives such as valacyclovir, ganciclovir, and valganciclovir. Now, trifluridine is given topically. It used to be given more commonly in the past, but now it is not given as commonly because it has its fair share of adverse effects. How it acts is by inhibiting viral thymidylate synthase and specific DNA polymerases. It also gets incorporated in the normal cellular DNA. Therefore, it would be toxic to the person who is taking the drug orally and is not given as a systemic drug. It leads to formation of defective proteins and an increased mutation rate in the virus, and that's how it brings about its action. Not very commonly used these days. What we commonly use is acyclovir, which, depending upon the severity of the hepatic keratitis, we give either topically as 3% ointment 5 times a day or orally as 200 or 400 milligram tablets 5 times a day. Now, 5 times a day is quite a bit of frequency, and there are a fair share of adverse effects with acyclovir as well. Therefore, the other milder derivatives like valacyclovir, ganciclovir, or valganciclovir, which are actually prodrugs of acyclovir, are more preferred these days. All these drugs, they act by activated by the viral thymidine kinase, and they inhibit the viral DNA polymerase. So let's have a look at how these act. As I mentioned, valacyclovir or famciclovir, these are prodrugs. Once they are taken, they are activated into their form of acyclovir for valacyclovir or into penciclovir if you are giving famciclovir. Now, viral thymidine kinase converts them into acyclovir monophosphate, and eventually, by virtue of cellular kinases, it is converted to biphosphate and then into acyclovir triphosphate, which then gets incorporated in the viral DNA and causes a premature termination of the DNA chains. And that results in damaged DNA of the virus, and therefore the viral activity is countered. Now, there is a set protocol for giving these drugs in herpes simplex virus keratitis. We cannot give it randomly as per our own wish. So, if somebody is using topical trifluridine, 1% for epithelial keratitis, it is given quite frequently, about 8 to 9 times a day, for about 7 days if you have a dendritic pattern, which is followed by tapering doses, not to be extended beyond 21 days. If you have a geographical pattern where the dendrites have fused and you have a much larger corneal involvement, then again, the format is similar, but you may need to increase it slightly from beyond 9 times a day for 7 days. And the tapering can be much slower, but still we cannot give it beyond 3 weeks. Preferable to topical trifluridine is ganciclovir gel in the concentration of 0.15%, given 5 times per day until healing is seen in the dendritic ulcers, followed by 3 times per day for 7 days, and the same is given for geographical ulcers. If the disease is more severe and it's not getting resolved with just the topical formulations, you can also add oral drugs, either acyclovir, valcyclovir, or famciclovir. Acyclovir is given 400 milligrams 5 times a day for 7 to 10 days in dendritic ulcer, and the dose is increased to 800 milligrams 5 times a day for 2 to 3 weeks in geographical ulcer. So the dose is doubled and the duration is also increased. Better than that is oral valcyclovir or famciclovir, since the frequency of the drug dosage is just twice a day. So 500 milligrams twice a day for 7 to 10 days, or double, which is 1 gram 3 times a day for 2 to 3 weeks, right? So you just memorize either one of them to answer in your exam. The dosage is less for dendritic form as compared to the geographical form. When we see stromal keratitis, then since stroma is involved, Steroids have to be added. Topical prednisolone in the dosage of 1%. In cases where there is no ulceration, we can give it 8 times per day with tapering over 10 weeks, depending upon the response of the patient. But once we have ulceration, we know that there is some infective element involved. We cannot give it very liberally. So the usage is limited to once or twice a day, but there is no clinical data as such to support the duration for this. So in an ulcer patient, if there is stromal involvement, I think we better leave it on the clinician to decide how frequently they want to give. In all these cases of stromal keratitis, oral agents are added. Acyclovir is given in a lesser dosage than what we were giving for epithelial form. So 400 milligrams BD or 800 milligrams 3 times or 5 times per day for a week to 10 days. Oral valcyclovir 500 milligram once a day or a gram of it 3 times a day in cases where there is ulceration. Similarly, in endothelial keratitis also, therapeutic dose of topical steroids is given along with therapeutic dose of oral antivirals. So for stromal and endothelial keratitis, steroids are given, but for epithelial form, there is a big no for steroids. So in endothelial keratitis without any ulceration, prednisolone is given 6 to 8 times per day, followed by tapering, which is dependent upon the response to the drug. There is no data to support the duration. So however you see that your patient is responding, you give the medication for that long. If there is ulceration, then oral drugs have to be given, and we have to be cautious in giving oral steroids, topical steroids, although they are given, but you have to monitor the patient closely. In cases with recurrent infection of herpes simplex virus, prophylaxis is a must. So the indications of giving prophylactic oral antiviral drugs is if the patient has multiple recurrences, especially of stromal keratitis, if there is recurrent inflammation with scar reaching the optical axis. So, it is coming in the visual axis and is going to compromise the visual acuity of the person. And you therefore want to address this recurrent inflammation by giving the drugs for at least 1 year. If the patient has more than one episode of herpetic keratitis with ulceration, then again it is better to give prophylactic therapy. After a corneal transplantation, which was done for herpetic scarring of the cornea, we definitely have to give a long-term prophylaxis. In post-operative cases with ocular herpetic simplex virus, or if there is a history of ocular herpes simplex virus during any immunosuppressive therapy. For example, in patients with HIV or other immunosuppressive disorders, there again, we know that any immunosuppression can cause flare-up of herpetic infection. Therefore, acyclovir is given in the dosage of 400 milligrams twice a day, valcyclovir 500 milligrams once a day, or famciclovir 250 milligrams twice a day for at least a year. Then comes another important category, and that is of fungal keratitis. Now, as this image shows, the severity of fungal keratitis can vary from a small involvement to massive involvement of entire cornea with even hypopyon formation. So the manifestation is severe and myriad. Therefore, we have to be very particular in which antifungal drug we give for fungal keratitis patients. So the role of corneal scraping in culture cannot be overemphasized in these patients. So we have 4 main categories of antifungal drugs. The first one is polyenes. These are agents that consist of large number of double bonds. And 2 most common antifungals belong to this group, amphotericin B and natamycin. The other category is azoles, which is divided into imidazoles and triazoles. Imidazoles include clotrimazole, econazole, miconazole, ketoconazole, and triazoles include fluconazole, itraconazole, voriconazole, and posaconazole. The triazoles are a little bit more effective than imidazoles, and so we would be focusing more on them in the subsequent slides. The next category is echinocandins, and they include caspofungin, which is given in refractory cases of fungal keratitis. And we also have flucytosine, which is a fluorinated pyrimidine. So let's start with polyenes. Now, how do polyenes work? Polyenes are very smart drugs. They bind to the ergosterol in the fungal cell membrane, leading to formation of large pores in the cell membrane, and hence they increase the permeability, which leads to leakage of especially important ions like potassium and other enzymes from the fungus. That leads to selective death of these fungal cells. So it integrates into cell membrane, creates a pore or a channel, and results in leakage. The action of this group of drugs is concentration dependent. More the concentration, more is the killing action. There is no standardized ideal dosing schedule which has been documented for this group. However, it is initially in a given half hourly in the initial loading dose with a gradual reduction to about 6 to 8 times per day. There is poor penetration of this drug through the intact epithelium. So if there is a breach of epithelium, then the action of this drug is better noticed because the drug is able to penetrate the cornea. The two most important drugs in the category are amphotericin B and natamycin. If you are asked a question, which antifungal has the broadest spectrum, then it is amphotericin B. It is also the drug of choice for candida infection, though it also works for cryptococcus, histoplasma, blastomyces, coccidiosis, and Aspergillus fumigatus. This drug is poorly soluble in water, and the important thing to know is that it is highly photosensitive. Therefore, it should be stored in dark amber colored glass bottles in refrigerator at a temperature of about 2 to 8 degrees centigrade. The solution of amphotericin B is prepared by reconstituting the parental formulation. So it comes as an injection and we dilute it and create 0.15% solution. Remember, the broadest spectrum, the drug of choice for candida, and photosensitivity. These are three very, very important characteristics of this drug. Then comes natamycin, which again is quite frequently used because it is drug of choice for filamentous fungi, such as Fusarium, Aspergillus, Cephalosporium, and Penicillium. Having said that, it doesn't mean that it doesn't act on other fungi, but it's the filamentous fungi which are most affected. The penetration of this drug is relatively poor as compared to amphotericin B. It is given as a 5% suspension. So whenever your patient is instilling this, you have to tell them to shake the bottle before they start putting the drops. By virtue of these suspension particles, sometimes you can have corneal deposits of the particulate matter in the areas where the cornea is denuded. How do azoles work? Now, azoles, they get combined with the fungal cytochrome P450 enzyme. And what they do is they inhibit the ergosterol synthesis, which results in the disruption of the membrane function of the cell membrane of the fungus. And they also, in turn, increase the permeability. If there is increased permeability, there is leakage of fungal content from inside the fungal cell. And eventually, there is impaired fungal growth and cell death. So as I already mentioned, triazoles have longer half-life and they have better penetration in intact corneal epithelium than imidazoles. So triazoles are more commonly used as antifungal agents. They are not fungicidal but fungistatic. Out of these azoles, topical voriconazole is used in recalcitrant cases of fungal keratitis, which are especially not responding to natamycin. 2-hourly dosing regimen is sufficient to treat candida and aspergillus, but since fusarium is a little bit more resistant to any sort of drug therapy, we need an hourly dosing of topical voriconazole for fusarium keratitis. Now, one of these very landmark trials regarding the fungal keratitis was the MUTT trial, MUTT, where M stands for mycotic, U for ulcer, and TT for treatment trial. What this trial showed was that natamycin is superior to voriconazole in terms of the final vision, the rate of perforation, and the need for doing a therapeutic keratoplasty in cases of fusarium keratitis. Now, as we can see here, that for fusarium, we are requiring quite a bit of frequent dosing of voriconazole, unlike for natamycin. So, just remember, although voriconazole comes into its action in cases where natamycin is not working, but still for fusarium, natamycin retain its superiority. Oral antifungals include ketoconazole, itraconazole, fluconazole, or voriconazole. Now, as we have repeatedly learned in the past few slides, that the topical drugs of this category have poor penetration, and that leads to intervals of subtherapeutic levels of drug in between the doses. And giving an oral antifungal can help maintain a constant therapeutic level of antifungal drugs in the aqueous. So we are actually just boosting up the effect of topical drugs. When do we add oral antifungal drugs in a case with fungal keratitis? When the size of the ulcer is more than 5 millimeters, or it is involving more than 50% of the stromal depth. If there is sclera or limbus involvement, if there is endophthalmitis, especially candida endophthalmitis, if you think that the ulcer is going to perforate or it has already perforated, in children with fungal keratitis, and after keratoplasty for a case with proven fungal keratitis. So, to prevent recurrence in those cases, we give oral antifungals. Now, oral ketoconazole or itraconazole, they have good penetration. They are relatively inexpensive. They are highly protein bound and therefore are to be taken with a meal. But this group of drug is hepatotoxic. So every 3 weeks, a liver function test is done. Oral voriconazole, the oral bioavailability is good, about 90%. The plasma protein binding is moderate, but this drug is also metabolized by the liver. Therefore, getting a liver function test before starting and during the therapy is imperative. This drug is taken either an hour before or 2 hours after the meal. It achieves its minimum inhibitory concentration levels in plasma, aqueous, and vitreous after oral administration. The problem is that oral voriconazole has its own fair share of adverse effects. It causes visual disturbances, and many a times people notice color vision changes and photophobia after taking oral voriconazole. And this drug is completely contraindicated in pregnancy. MUT2 trial showed that there is no benefit of adding oral voriconazole in severe filamentous keratitis. So, in severe filamentous keratitis, if we want, which is not responding to natamycin, we can give topical voriconazole, but there is no advantage of giving additional oral voriconazole. Coming to the last category of antifungals, we have fluorinated pyrimidines, which the example is flucytosine. Now remember, the others were inhibiting DNA, and flucytosine is inhibiting RNA. This drug is active against Candida and Cryptococcus and generally is used in combination with amphotericin B. It's not used very often because it is notorious for having a high incidence of acquired resistance. I'm sorry, there's another category which is echinocandins and which includes caspofungin. Caspofungins work very well for Aspergillus species, although they are not very effective against the Fusarium species. They interfere with the synthesis of the fungal cell wall by inhibiting the synthesis of D-glucane, leading to lysis and fungal cell death. Basically, all the drugs are what they are doing is they are entering into the fungal cell and damaging one or the other part. So, echinocandins are working on the cell wall, polyenes were working on the cell membrane. The azoles, they were targeting the biosynthesis pathway in the endoplasmic reticulum of the fungal cell. The flucytosine was working on the nucleus and inhibiting the nucleic acid synthesis. So, whatever is happening is trying to damage the cell in either its production mechanism or in the barriers that the cell has, either in the cell membrane or in the cell wall. So, all the drugs are trying to break the fungal cell one way or the other. So if we just look at this flow chart, how are we going to change our therapy? We initially start with topical natamycin once we see the patient in most cases. So topical natamycin 5% is started. If in 7 to 10 days you see a good response that is coming, the size of the ulcer is reducing. If there was hypopion that is also reducing, we continue with topical natamycin. But if there is poor response and you see that the cornea is getting thinner, there is a likelihood of a perforation happening or a perforation has already happened, then you give additional topical voriconazole. And if to that also there is poor response, you plan the patient for therapeutic keratoplasty. But if after adding topical voriconazole, you see that the patient is having good response for a week or 10 days, you continue with topical natamycin and voriconazole. Sometimes, if the response is happening but not to the desirable level, we can give the injection of intracameral or intrastromal amphotericin B. Intrastromal means within the stromal layers of the cornea, and intracameral means injecting in the anterior chamber. So these can boost the effect of the topical drugs. If with this intrastromal injection you get good response, you continue with the topicals. But if there is poor response, either you can consider taking up the patient for therapeutic keratoplasty, or you can repeat the intrastromal injection up to 3 or 4 injections within 72 hours. But if even then you don't see a response, it is better to do a therapeutic keratoplasty. You can get an MCQ wherein you can be asked, what are the general antiseptics which have antifungal properties? And the answer to that would be chlorhexidine gluconate or topical silver sulfadiazine. Now, these are also fungicidal drugs. Coming to the next category, which is corticosteroids. So we can have short-acting, intermediate-acting, or long-acting steroids. The short-acting ones include hydrocortisone, cortisone, and prednisolone. The intermediate-acting ones include triamcinolone and fluprednisolone, while the long-acting ones include dexamethasone and betamethasone. The commonly used drugs by us in the post-cataract surgery treatment is dexamethasone and betamethasone. These are also used after acute iridos for patients with acute iridocyclitis. Amongst these, if we look at the anti-inflammatory properties, the highly potent ones include betamethasone, dexamethasone, and fluocinolone. The medium potency drugs include triamcinolone, loteprednol, and dexamethasone sodium phosphate or fluorometholone, and the lower potency ones include hydrocortisone. Higher the potency, more the risk of glaucoma, which these drugs can induce. So we have to be very cautious whenever we prescribe steroids to our patients, because once they see relief in their symptoms, they become dependent on the drug. And steroids are the most commonly used, rather abused category of drugs. So whenever you prescribe steroids, you tell the patient that if you keep putting the drug without prescription of the doctor, then you may end up with glaucoma and cataract. The cataract can still be treated with a lens, but the glaucoma is irreversible and potentially blinding. As I was talking about the indications, the topical steroids are used in severe cases of allergic conjunctivitis, in scleritis, in uveitis, that is acute iridocyclitis, allergic keratoconjunctivitis, and even after intraocular and extraocular surgeries. Systemic steroids are used in pathologies which are usually behind the lens, such as posterior uveitis, optic neuritis, And in cases with corneal graft rejection, also we use systemic steroids to uh, to cause immunosuppression so that graft rejection does not happen in early postoperative period. But remember, never give steroids if you are suspecting an active infection. Systemic steroids have ocular as well as systemic adverse effects, and this can come as a short note in your exam. The ocular adverse effects include glaucoma, steroid induced cataract, which is usually posterior subcapsular in nature. There can be activation of some infection, or there can be delayed wound healing. Especially in diabetics, we have to be very careful in giving steroids. Systemically, if they are taken for a long period of time, they can cause peptic ulcer, they can cause increased blood sugar levels, osteoporotic changes, mental changes. They can even result in activation of tuberculosis in some patients. So you have to be very, very cautious. And sometimes it's better to run a battery of tests before starting patients on systemic steroids. There are non-steroidal anti-inflammatory drugs also, such as flurbibuprofen, indomethacin, or ketorolac. They can be given as topical drugs, and sometimes we need to give them orally. Especially indomethacin is a wonderful oral non-steroidal anti-inflammatory drugs. So for wherever where the steroids are contraindicated, these drugs, they serve a wonderful purpose. In patients with episcleritis and scleritis, uveitis, cystoid macular edema, topical NSAIDs are given, and they are also given preoperatively to help maintain dilatation of the pupil. But sometimes, when you want to take care of the cytokine storm that can happen after an intraocular procedure, oral indomethacin can also be given. Now, there is a class of drugs which we don't really call as drugs. We don't prescribe them to the patients, but we use them day in and day out in our OPDs. So, one of the most common diagnostic drug that we use in our OPD is fluorescein dye. It is used for staining corneal abrasions to see how much is the corneal defect in cases with corneal ulcer, corneal abrasions. For doing applanation tonometry for checking intraocular pressure, we need to stain the tear film, and then we get these green Myers when we see under cobalt blue filter. In order to find out nasolacrimal duct obstruction, it's while we are doing syringing, we use this dye in the fluid, and if in the nasal cavity you get fluorescein stained fluid, that means there is no obstruction in the nasolacrimal duct. And it's also used for fluorescein fundus angiography. Whenever you're using fluorescein dye, make sure that the patient is not wearing soft contact lenses, else the dye will stain the lens. And it is better to use strips because the drops need to be prepared freshly. If you're using old drops, the drops can be contaminated by Pseudomonas. So this can also come as an MCQ question, which is the most common agent which can infect fluorescein drops, and the answer to that would be Pseudomonas. There are other strips or other dyes that come impregnated in strips, and one of the most commonly used dye in patients with viral keratitis is the rose Bengal stain. The strip is usually impregnated with 1.3 milligrams of rose Bengal. The problem with rose Bengal dye is that it causes immense stinging. So before putting rose Bengal dye, topical anesthetic such as proparacaine is instilled in the eye, and after that, rose Bengal stain is put. It stains the devitalized epithelium. As you can see here, there is a bright pink strand of devitalized epithelium. This is used in patients with severe dry eye and in herpetic keratitis. Now, lissamine green is another dye which is usually used for patients with dry eye. And dry eye, remember, is not just involving the cornea, it also involves the conjunctiva. So lissamine is beautifully taken up by conjunctiva. It is available in the concentration of 1%, 2%, or 3%. This dye has a high affinity for staining dead and degenerated cells, including mucous strands. And it's very preferred for staining the bulbar conjunctiva. So in patients with keratoconjunctivitis sicca, or in patients where you want to see what is causing the dry eye, we use this dye. And in patients where contact lens fitting is done, to a certain proper fitting of the contact lens and to look for any contact lens induced conjunctival staining, we use this dye. Another commonly used dye during cataract surgery and certain vitreoretinal surgeries is trypan blue. For anterior capsular staining in a cataract surgery, it is used in the concentration of 0.06%, while for retinal surgeries, it is used in the concentration of 0.15%. So this too can come as an MCQ. The dye does not penetrate the intact capsule. So it just stains the capsule, and once you do the capsulotomy, it just helps you to visualize uh, the entire stained capsule. Especially in patients with mature or a hypermature cataract, capsular staining should be done. It also selectively stains the Tenon's capsule, and hence, in cases with enucleation, it helps you to do layered closure. It also stains epiretinal membrane when you are doing retinal surgeries. In corneal surgeries, it is used to stain and strip the Descemet's membrane in Descemet stripping endothelial keratoplasty, and in stripping the corneal endothelium from the donor button in deep anterior lamellar keratoplasty. So there are several uses of this dye. So you can get a short note on dyes used in ophthalmology. So there you can talk about fluorescein, trypan blue, rose bengal, and lissamine dye. So with this, we conclude our today's session, and I open the house for any questions that you have for me.